Alright, Sarel Gaur MD. Let's jump into search pattern. Alright, so I'm going to do a couple videos I think on this. This video I just want to kind of talk about the search pattern, not necessarily like a step-by-step, but just kind of a general sense of it, and then maybe in another video we can actually go through step-by-step like an actual dictation template and kind of how to understand it and go through it. But basic search pattern is really it's just meant to basically look at the anatomy in an organized way and make important findings. So to me, basically, when I'm looking at the cervical spine, I basically look mostly on the sagittal to start. Always start with the sagittal. And I basically think about cord and column. I think about column and cord. So cord, column. Those are the two main components you really want to look at. You really don't want to look at much else, especially when you're starting out. Because if you look at all the other stuff, you're going to get kind of, you're going to lose your focus and you're not going to make the important findings. So really you want to focus on looking at the cord, looking at the column, looking at how they interact, and diagnosing disease. And keep in mind that these structures interact in a very specific way. The column gives you stability, it gives you height, it's how your body allows you to stand upright, and then you have the cord, which is very sensitive tissue extending inferiorly from the base of the brain down, and then innervating your body at each level as it splits off into nerves. So again, just think cord and column. So search pattern is really going to be dictated upon what you're most likely to see in practice. So you sort of have to have an idea of what type of diseases you're going to be trying to see in practice. And when I was at an academic medical center for training, I saw a lot of different things. We would see some kind of, quote unquote crazy things. We would see big cord tumors, which are very rare, but we'd see them. We'd see congenital malformations of the cord and the cauda equina. We'd see large metastatic lesions that are transspatial, that involve the column, thecal sac region, and posteriorly into the posterior elements. We'd see a lot of weird arthritis things with maybe large synovial thickening involving C1, C2. But when you go into private practice, when you go into hospital-based practice, when you go into community practice, you're really going to see a lot of degenerative disc disease. So it sort of changes your outlook on how you look at these. But regardless, you kind of want to start with, again, thinking about the cord, thinking about the column. I typically start with the column, and I initially address the alignment. You might think, what's the significance of that? And well, the significance is that if the alignment is off, you could be picking up some abnormalities. If there's not a nice gentle curvature or lordosis, you could be picking up on potentially a traumatic injury where there's one level is traumatically injured and there's a focal change in the curvature, or maybe this whole thing is straightened and stiff and a degenerative neck. So start with the curvature, then kind of move into signal, and basically looking at the vertebral bodies, looking at the signal of the vertebral bodies, looking to see if there's infiltration. Marrow infiltration is typical of METs, so there's also other processes that can cause it, but it's just something I'll be looking for. It should be kind of fatty and bright on the inside here. So if that signal is gone, that's a good indication of maybe there's infiltration. That could be metastases, it could be infection, it could be a few other things, but those are some things I'm looking for. Also looking at the discs and looking for disc desiccation, disc arthritis. If it's present, I'm going to describe it better on the axial images, so I don't go too crazy into detail initially, but just want to know which levels are down. And disc should normally have a high signal centrally and a low signal more peripherally. And so kind of, cord column moving from the, alignment, looking at the vertebral body signal, looking at the disc signal. You can sort of now move, I think, into the cord. And looking at the cord, initially you might be thinking, well, what am I trying to look for? Well, you're really looking for any abnormal signal, and it takes a while to sort of understand the normal signal and stature of the cord. You got to look at a lot of these cases. But once you get it, you sort of get a sense of what the normal variation of signal in the cord is supposed to be. theoretically there could be a lot of lesions along the cord. There's primary cord neoplasms, which can occur just like there's primary brain tumors, and they're going to look really strange and aggressive, and you can pick them up if you look at the cord. There could be inflammatory myelopathies. You could have someone with MS, and they're going to have high signal plaques throughout the cord. You could have AVMs of the cord, which will be serpiginous, strange-looking vessels surrounding the cord, infiltrating the cord, with cord edema. You could have traumatic injuries of the cord with edema and swelling and internal hemorrhage formation. You can get, just from chronic degenerative disease, you could get myelopathy, thinning, kind of loss of the bulk of the cord. So again, looking at the column, looking at the cord, kind of that's how I kind of start out the search, and then kind of from there I move into the axials, and then kind of I'm looking at each level, and I'm just basically looking for central canal stenosis and neural canal stenosis and trying to describe it. So you come down to this level. This is 2, 3, 4, 5, C5, 6. I'm seeing it here on the axials. So I have disc here. I have an oncovertebral joint here. I have the facet joint here. And I can basically make a diagnosis. Now again, typically what I'm going to be seeing is degenerative disc disease. So I'm going to describe the relationship of the disc to the central canal, where the fecal sac is, and describe any narrowing or any impingement upon the cord. So a lot of times we'll describe it as a disc osteophyte complex if it is degenerative. Describe if there's central canal narrowing. And then I'm going to analyze these neural canals, these passageways for the nerve tissue to exit to either side. And I'm going to describe if there's facet arthropathy, if there's uncinate joint arthropathy, if that's causing narrowing of the neural canals. Often it's asymmetric. Often it'll be that just on one side there's a bulky facet with prominent uncinate joint disease, and there's narrowing of that canal, of that foramen as that nerve passes through. Then just to kind of round out the exam, I kind of look at the neck soft tissues, just looking for anything big, anything gross, anything that you don't want to miss. And then also making sure to kind of look at the posterior fossa structures a little bit. And that's kind of about it. I mean, that is pretty much it. Basic search pattern is you want to look at the column, you want to look at the cord, you want to look at the axials, and you want to look for central and neural canal stenosis. And again, depending on what you're used to seeing in your practice, again, for me, it's going to be a lot of degenerative disc disease. You're going to make the majority of your findings in that way. We can continue another video. Maybe we'll talk a little bit more in detail about the exact search pattern, including we could reference the template as well. So, something to look forward to. Sarel Gaur, MD.